at the ESD, they had the Liberates trial where post ACS, they put a flash and they found, though none of them was significant, but they found better time in range and lesser hypoglycemia. So do you think a monitoring post ACS will change with this kind of study? Will we be using more CGM on these patients? Dr. Sethi, for you, sir.
Okay. Well, the results were a bit surprising, that individuals were monitoring their glucose levels by flash glucometer did spend a shorter time in hypoglycemia and slightly longer time in range, but none of them reached statistical significance, which was really not very easy to understand. That means that if you are doing your self-monitoring of glucose in patients who are on secretagogues and insulin, you can put it the other way around. That's good enough. You gain about 71 minutes of target in range, and you had 30 odd minutes of less hypoglycemias, and the analysis were different. If you use some different model, then the data was showing slightly higher numbers. Otherwise, it is surprising. That means to say that something more is required other than monitoring. And typically, I am not blaming cardiologists again, though we are bashing all of them today. Is the person who treats those people is also important. A typical patient who is in coronary care unit who gets discharged might not have access to modification in therapy, might be on insulin when he probably does not require it. There are many number of people, and there are good drugs now which cause no hypoglycemia, which can be given in this situation. So coming to the study per se, it was a bit surprising. Probably the therapy was also not modified as well. If you are modifying therapies based on monitoring, then only you will get some results. Otherwise, just like getting a logbook and having no intervention in the days gone by. So if you're having a flash data which showing that your target in range at 90 days is just 71 minutes more, I think that's disappointing. But what it means is that it requires greater amount of monitoring. And if you're monitoring it very well, you might be extending your time in range. The mortality data also numbers were too small. The deaths, I think, occurred in about 3 people in the intensive group and the flash group, and about 6 or 7, but the numbers were too small to compare. And then the MACE events were the other way around. They occurred more frequently in individuals who are on the flash monitoring. So I think there is too little of data here, but it looks like it's doable. And as it becomes a norm, which is unlikely to be the norm for days to come till it is available with a reader all the time, I don't think this data is very exciting. It stresses the need for monitoring, but the differences were not really statistically significant, and that was the most surprising part. Probably there was something wrong with the therapy. The therapy, if it has been modified based on that data, we would have had different results. That's my guess.
Thank you so much, Dr. Sethi. You compressed the entire study in a fantastic format. Dr. Mittal, a slight tweak to this, that would hypoglycemia, is it a risk factor or a risk marker for any kind of cardiovascular event? You know, we try to catch the dots or connect the dots and make hypoglycemia the villain everywhere. Is that a big villain? Do we need to put these kind of monitoring to catch it? Is an SMBG good enough?
So, well, how much of an impact the monitoring will have on endpoints remains to be seen. I mean, that's pretty hard to show outcome data with that, but I'm sure someone will look at it. But of course, we know that hypoglycemia is deleterious. There's no question about it. When I was a resident, my professor used to tell me, in a cardiac patient, you shouldn't get hypoglycemia, whatever else you do. Okay, so there's really nothing new about that, but there's plenty of solid data to suggest that occurrence of hypoglycemia can aggravate, of course, in the acute stage, actually precipitate a coronary event, precipitate arrhythmias for that matter, but also recurrent hypoglycemias have a deleterious impact on outcomes. I think that's pretty well established. So I do think that one of the key things about managing diabetes, especially in a population with comorbidities and with other issues, is to avoid hypoglycemia. So where we have been using flash monitoring, for example, in a somewhat aligned but different, slightly different situation is, for example, someone comes for surgery from a distance of whatever, you know, and is due for some elective surgery or some surgery, and you have to give a clearance and the sugars are all over the place. So you institute insulin, now you put him in the hospital, the costs go up a lot. So we institute insulin on an OPD basis and ask the person to, we attach one of the flash monitors, you know, and maybe the patient can come every day even, because we don't have the readers for everybody. And you can take a download and you can, within 3-4 days, you can give a clearance for surgery. I have no data to scientific data, but I am in clinical practice. I have used that fairly successfully to bring glucose to a certain level where you can be confident that it's okay to go for a particular surgery or not. So that's one other way that we are using it. We also think that we have used it in post-CABG patients also when we are sending them off. If they're still staying in town and whatever for 2 weeks after the surgery, post-transplant on steroid, we have used these with varying degree of success, I would say.
Thank you so much, Dr. Miller. Dr. Sujay Ghosh, your take on this?
Right. I would agree with Professor Mittal that, you know, we have always been taught that hypoglycemia is a risk for cardiovascular event. But again, to put a spanner in the works, you know, if you look at the linagliptin glimepiride study, Carolina,
no difference.
You had more hypos with glimepiride, and yet you were not able to kill more people with glimepiride, which was assuring, at least in a country like India. I think the major problem with this particular study that we are discussing, Libre, is the methodology and the patient selection. Now, you've taken people who are post-ACS on sulfonylureas and insulin, and you are expecting that people will have more hypos, and that hypo will kill people. Now, this would have been a good study if you had people who have, you know, brittle kind of diabetes, insulinopenic diabetes, people with bad kidneys. Because I don't think we still have access to the full text of the article. But if you look at that group of individual, that would make them susceptible to hypoglycemia. Whereas standard someone who had some degree of hyperglycemia, relatively well controlled with say 1 milligram of glimepiride or 2 milligrams of glimepiride, I'm not going to make a huge difference in the glycemic control. I'm not going to increase the huge risk of hypoglycemia. Someone on basal insulin, otherwise okay, I'm not going to make a big difference. And therefore, I think I would like to have a closer look at the trial design and whether, you know, it was powered enough to, you know, have those so many kind of hypo events in the first place, and then that hypo event translating into cardiovascular event. You know, it's a long shot.
Absolutely. So, sir, I'm going into a rapid fire round. We've got like 5 or 6 minutes. So two questions, half a minute answer. So one which was presented was that GDM were followed up postpartum. They had 41%, which is fantastic if as far as India goes. And there are 2% people who were developed diabetes and 17-18% with pre-diabetes. So do you think that that's a window of opportunity for all of us? Should we have guidelines where postpartum GDM should be followed up and they should be properly so that we can prevent diabetes in them? We start with Dr. Ghosh.
I think the guidelines are there. The data is there. The evidence is there. It's about implementing.
Absolutely.
How you implement what we know is the biggest challenge in NCDs. You know, we've got to figure out a way for our own country in some manner so that we can actually implement the knowledge that's already there. I think that would be my take.
Thank you so much, Dr. Sethi, your take?
Yes, it's the problem of implementation. There are factors of nutrition, infant feeding, mother-in-law, mother, social factors. These are more important. The girl in question is very keen to do. A husband is a peripheral issue. He just creates and goes away. But the problem is that these people are like pre-diabetics. Many people say, had I known, I would have done this. But pre-diabetics and gestational diabetes who know for sure that they'll get diabetes, they do nothing about it. And it's most frustrating to see these people coming after 2-3 years saying that you had looked after the previous pregnancy, why didn't look after me now also? So, but this is a common trend, and this changes. And this involves, I'm not joking, many social, medical, and also factors between the nutrition, the obstetrician, and also the endocrinologist. The people who are on our follow-up, and there would be very few people. They would be saying at least the recommended test may not be thereafter, but at least after 6 weeks. But what happens afterward? They just lost a follow-up till they become pregnant again.
So I think, Rajiv, this is an important area, even more important area for India. Because if you look at the statistics of GDM in India, they're appalling actually. And the global figures of 10% and all don't apply anymore. Newer studies are showing, I was reading the other day for some other meeting at 26%. And there are smaller studies have shown even 35, 40%. I don't know what to make of that, but definitely even the WHO gentleman said that 25%, 26% probably is GDM. Now, that is a huge number. That's one part. The second part is one of the studies that I reviewed as a reviewer many years ago, 3 years, 4 years ago, clearly showed that at 6 weeks, if you did a systematic glucose tolerance test in everybody who was discharged at 6 weeks after delivery, you would find that almost 20% are pre-diabetic at that point. So that's a huge population. And actually in this particular study, and I can send it to you if you like, 6.4% already had diabetes. And these were not known. I mean, we don't have a very good history of the past, but they were not known diabetics. So what I'm saying is that it's there, and there are so many challenges that Dr. Sethi said. It's exactly the same experience across the country. I think it's critical for us to get into this zone, emphasize that every GDM is going to be, we should say every GDM is going to be a diabetic, unless they take precautions. That's what I tell them, So that's my take on it. Bipin saying something.
No, I think Nick has already done some work called the Bridges study, wherein they found that at 1 year, 30 to 40% women were diabetic already.
So
5 years, that 50% people were diabetic. And they are doing that in terms of maternal counseling, family counseling, and there is study going on already with them. So the data is really, really appalling. And if it can be implemented, as Sujay said, I think implementation is a problem. We need to work hard on this.
The wing study, I think you're talking about. Anyway, yeah.
So we go to the last question, again, rapid fire. We all know that, ethnicity loads the gun and we pull the trigger. So that there was an article which said that ethnicity and obesity in early onset type 2 diabetes, a retrospective study, showed that Asian Indians are diabetics at a younger age with lesser BMIs compared to Caucasians. We all know that, but retrospectively means it's getting more and more, it's hitting on our face that we are younger with diabetes.
I think it's to do about your traditions, the culture, the way you were brought up over centuries in terms of your diet, your exercise and lifestyle. So if you look in India, we go to KFCs and McDonald's thinking that it's a great place to go to. And if you go to, say, United Kingdom, that's where people go to save money because, and in India, you'll find that the rich are fat. And in the Western world, you will see that the rich are thin. So I think it's about cultural shifts which happen, perhaps more than the genes and more than the ethnicity. That's my view. That's probably the reason, because we've suddenly changed our lifestyles, we are now in that zone as Southeast Asians that we are getting more and more of these non-communicable metabolic disorders. Over a period of time, as we get wiser, as as we as parents, or maybe the next generation as parents realize that, putting on weight is not a good thing. The food that you are eating, the junk that you're eating is not good for you. Probably that will change. And I think it's got to do with the economic background and the social background rather than pure ethnicity.
Thank you so much, Dr. Sethi. Dr. Mittal, your take?
Yeah, I think too much is made of ethnicity here. Yes, it's there. There's no question that ethnicity, but the genesis of that ethnicity induced effect is not just the ethnicity. It's not something in the gene. At least we don't have proof of that yet. And I think it really is very much a lifestyle issue. And as you very rightly said, in the US, we used to say that the Indian middle class is now like the US lower socioeconomic status. Exactly the same way we are going in terms of disease. And even in India, the upper socioeconomic class is very careful and very conscious now about their health. So it's a shift cultural. At the same time, you cannot ignore the centuries of deprivation that our bodies have been subjected to with low protein diets and kids being born of malnourished mothers who have high amount of body fat and low amount of lean mass at birth. And when these are exposed to the energy dense environment that modern world brings with it, then they can't handle it. So this is, I think it is more you can call it a thrifty gene hypothesis. You can call it a cultural change. I think it's much more that than directly in our genes. That's my feeling. I may be proved wrong later, but right now I think that is much more likely.
Thank you so much, Dr. Min. Dr. Sethi, your take?
It's just slightly different. If you just listen to the lecture, Golgai lecture was very interesting. They tried to show that the Asians, compared to Europeans, have got genes which produce more insulin deficiency kind of syndrome rather than Caucasian, where there is something to do with lipid oxidation and insulin resistance. So there is some genetic factor, and they very elegantly prove that both resistance and deficiency are required. So if you are born with some kind of genotype which is likely to make you insulin deficient because the cells cannot, we say, rise up to the challenge, then as what Sujay said and as Mittalji said, you're not going to have that compensatory hyperplasia sufficient enough to overcome this insulin deficiency. So I guess both the factors are there, but I agree. Genes have not changed in the past 30 years. Environment has changed vastly in the past 20 years. And this epidemic is possibly more to do with the environment than the genes alone.
Thank you so much, Dr. Sethi. I think in 1 hour, we had a condensed ESG and it was fantastic discussion. Who says we have to go to Austria or we have to pay 150 euros for the ESD when you can get everything in 1 hour? Thank you so much, Dr. Mittal. Thank you, Dr. Ghosh, Dr. Sethi. And I think Dr. Shashank has left. Over to you, Dr. Agarwal, for your concluding remarks.
Thank you, Rajiv, for doing a great job.
Thank you so much.
Very, very nice. Yeah.
Thank you very much. Thank you. Thank you.